This week on the BackTable podcast.
It's just such a great procedure for the right patient population. I just would hope that every interventionalist, if they think about this as an option for your patients, because for the right patient, it changes their lives. It changes their last few days and gives them great quality of life for time with family. And I just want to reiterate that this is what this was brought here for, is to help those patients through a very difficult time and to always keep that in the back of your mind for a possibility.
I'm your host, Dr. Baheti. I'm an interventional radiologist in Tacoma, Washington. I have the pleasure of bringing on two guests today, both from Mayo Clinic, Arizona. We have Dr. Alex Wallace. He's an interventional radiologist, as well as Lisa Rotellini. She's a physician assistant in general surgery, but formerly was an IRPA and had a really big role in starting this program. So Alex and Lisa, thanks so much for being on the show.
Thank you for having us.
Thanks for having us.
So our topic today is PTEG, which for the uninitiated, Dr. Wallace, what does that stand for?
Yeah, PTEG generally stands for Percutaneous Transesophageal Gastrostomy, although I think it was originally described as gastrotubing.
Gastrotubing. That sounds like a fun winter sport that I would do, gastrotubing. It's probably kind of a niche procedure. I know you guys have a lot of experience with it. How long have you been doing it for?
So I think we started the procedure in about 2014. Is that right, Lisa?
It is. It came as a result. It's kind of a fun little background story. So I was a physician assistant on the service, constantly getting consults for venting gastrostomy tubes for malignant small bowel obstructions. And with these patients, they had ascites, peritoneal carcinomatosis, or caking of tumor within the stomach. And so really all we could do at that time was place a nasogastric tube. Well, these patients were getting, mucosal ulcers. They were uncomfortable. It was poor quality of life. So I did a literature review and saw that Dr. Hidito Oishi in Japan had been doing a number of these as a procedure for venting in gastric cancer patients since 1994. And when I saw that was happening, I started to do more and more of a literature review and thought, can we bring this here? What can we do to start this in the United States? And thanks to the efforts of Dr. David Casper, I'd like to say that he helped MacGyver a way to do this here in the United States, because in Japan they had a kit. And so it's a kit that you can only get in Japan. So we had to figure out a way to use our American items to create this venting.
Oh gosh, that's kind of one of the coolest things about IR, right? Is we get to figure out how to do procedures using the stuff we have on hand. So is Dr. Casper retired now, or is he still around?
He's retired now. As a matter of fact, though, he did come back and support me. So with all of these efforts, and I had actually reached out to Dr. Hidito Oishi regarding placement and getting his input and helping me grow the program. And as a result, he invited me to Japan to present our data and to spend time with him. And I got to place PTEGs with him because he's not an interventional radiologist, he's a gastroenterologist. It was incredible. And so Dr. David Casper flew out to hear my presentation and to share our data, because he was a big part of this with me.
Oh, that's so neat. Oh man, it's like you get to meet a celebrity, you get to meet your hero. Well, okay, so PTEG procedure, you mentioned some of the indications for it. Dr. Wallace, could you kind of get me into kind of who might be a good candidate for this procedure?
Yeah, absolutely. I think Lisa touched on it briefly, but our main patients that really benefit from this are patients usually with malignancy who have a poor traditional gastrostomy access window through a transabdominal route. So gastric cancer patients with a significant amount of peritoneal carcinomatosis or omental caking that we don't want to traverse. Additionally, ascites is a really common indication. A lot of our patients have severe ascites, and while we can drain it, we're worried about leakage through the tract and poor healing and things like that. So those are our two main patients who benefit. Additionally, we've also seen surgical change patients, so patients who have large gastrectomies or a portion of their stomach that is herniated up into the chest cavity where we can't get a good percutaneous window, or patients who have intervening bowel that no matter how much insufflation you get, you can't move it either below the below the liver or get that colon out of the way. And so these patients really benefit from this kind of procedure.
Fantastic. Yeah. I mean, just kind of in community practice IR, we get tons of referrals for folks like this. And I think, most IRs are willing to give it a try, but sometimes it's just not safe, right? And there's nothing an IR hates more than failing, I think.
Absolutely. We bring all of our patients down and you never know what you're going to see. But when we fail, this is our good backup plan. So
cool. How many of these would you guys say you perform in, say, a month?
It's probably uncommon for us. We've run into, I think we reported about 69 cases since 2014. So it's about 5 to 10 a year, but enough that we get a good result over time.
And can I just add to that? I think what is our biggest challenge with getting patients is that we get them late stage and not, we're getting these patients that are highly decompensated. So I think if you are willing and wanting to do this procedure, that you need to inform people that you are available to do this and what that looks like. And that's been something that Alex and I have talked about is how do we introduce this procedure a little bit more so that people are coming to us sooner. And I think we'd be performing more. It's interesting now with my role in general surgery, I've referred for PTEG because general surgery wasn't even aware that we could do something like this at Mayo Clinic, Arizona. So I think it's awareness will help drive more and more patients should they be appropriate candidates.
When you say kind of like they're too far gone, is it just like from a nutritional perspective or like they're not sedation candidates or what do you mean exactly?
I wouldn't say that they're not good candidates. I would just say that these patients are severely decompensated from their disease and from their nutritional status. These are patients that we could have potentially helped them a little bit earlier in their disease and not.
I'd love to add a little bit to that as well. A lot of our patients are going to hospice and we're kind of starting to rain down their care in an aggressive kind of form. And so that's often when we start to see these patients. And I think one of the things Lisa and I are trying to do is make sure that we inform our clinicians, our referring physicians earlier and earlier that we can get a hold of these patients faster and relieve their symptoms, give them better relief away from the nasogastric tube much earlier in their course. As we've shown, some of our patients can last with a PTEG up to 1.5 years without any issues. And oftentimes we're seeing them only have this tube for about 20 to 30 days or so before they go to hospice and unfortunately pass away.
Got it. Yeah.
However, we did have one patient that had it for 560 some odd days. It was her lifeline, and it gave her quality of life and time to be with her children. So we know that the tube can last for a long time. We know that it has that potential.
Oh, yeah. Is it pretty much just in adult patients, or do you do it in pediatric patients as well?
At Mayo Clinic here, we only see adult patients. So unfortunately, that's our only experience. But I can't imagine that it would work for pediatric patients as well.
Okay, well, let's kind of get into the nuts and bolts of it. Kind of walk me through the pre-procedure evaluation for these patients.
Yeah, absolutely. So for these patients, it's most important to go up and talk to them about the procedure because when most patients are doing research about gastrostomy tubes, they're going to run across transabdominal access and maintenance and management of that kind of procedure. So making sure that you talk to them about how we're getting from the neck to the stomach and what our goals are, either feeding or venting. But aside from that, talking about, risks and benefits, making sure that we have at least some sort of cross-sectional imaging of the neck is very helpful from the neck to the stomach to make sure that we can get there appropriately. That can be ultrasound or a CT of the chest, anything in that vein. It's also helpful to get a really good surgical and treatment history. So one of our failures has been due to radiation to the neck, and so it prevented the esophagus from being accessed under ultrasound. So making sure you do a thorough history of what kind of surgical change they may have, as well as any other treatments that may affect the neck or anything down to the stomach. And then lastly, we really consider this a high-risk procedure per the SR guidelines. So we're looking for platelet levels greater than 50 and an INR somewhere around 1.5 or less.
All right, yeah. Now, when you're doing your pre-procedure workup, do you make a decision about if you're going to go on the right or the left side, or is that something you decide in the procedure?
Yeah, it's a great question. So statistically, most of the time when the esophagus moves and translates, it goes to the left side. So almost all PTEGs are placed on the left. There have been some reports of it on the right, and every once in a while, the balloon translates to the right side. Generally, we can fix that just by pushing on it manually, but most often they're going to be left-sided placements.
Any other anatomical considerations that you make based on your pre-procedural workup?
Not so much. I think it's pretty straightforward after that.
Well, I think we also make sure they have a nasogastric tube so that we have access and how they're tolerating their venting. That is a good prognostic indicator for us for success of PTEG as well.
Yeah, okay. So how long do they have to have a NG tube and be venting for before you'll consider them as a candidate? And then I guess the corollary question is, are these all placed on inpatients or do you schedule these for any outpatients?
Usually we've had them, because there's very few places that place these, we've actually had patients transferred for the procedure and we've done them as an outpatient. Typically, though, they're usually inpatients, but now we're starting to see an influx of outpatients because palliative medicine is aware of the procedure that we can do, as is in oncology. And so they may reach out for an outpatient placement, but primarily most of them are inpatient, trying to transfer them to hospice. The other thing we look at, too, just to make sure, is we do these with general anesthesia. We attempted one with sedation and had a poor outcome. And so we talk about this. Alex and I went back and forth about, hey, do we start looking at sedation again? So really getting them worked up for anesthesia is part of that pre-procedure workup as well, to make sure that they could actually undergo general anesthesia.
As far as timing for having a nasogastric tube and, venting, I don't think we have any specific cutoffs, but generally if the primary team or the patient expects this to be a protracted course, then we're pretty happy to place these tubes. If for some reason the patient improves significantly, they can always be removed, although we definitely want to wait for the tract to form.
Okay, yeah. So that's a little bit different than a G-tube. So it's like, yeah, this is kind of what we're here for. Okay. And then walk me through kind of like a really straightforward PTEG procedure, kind of from soup to nuts.
Yeah, absolutely. It's definitely a procedure that you want two sets of hands for, because we need somebody both at the neck and someone managing the balloon that's in the esophagus. So after we bring the patient down, this is generally done with general anesthesia, as Lisa had mentioned. And so the patient's placed supine with their left neck exposed. They're generally intubated, but they don't necessarily have to be. Once they're there, they usually have a nasogastric tube. We'd like that to be in about an hour before the procedure with continuous suction. So that way we empty out the stomach in its entirety, really preventing aspiration, because a lot of these patients have bowel obstructions. Once we're there, we set up two tables. One is going to be a sterile table. That one's going to be at the neck, and the other one's going to be a non-sterile table. And that'll be closer to the head where the nose or the mouth is at. Through the nasogastric tube, after all the aspiration has been performed, we place a wire down and loop it into the stomach, remove the nasogastric tube, and exchange it for usually a 20 millimeter balloon, something short. I think in our facility, we use a Z-Med balloon. And we retract that over the wire into about the mid-esophagus. Then the physician is at the sterile side with an ultrasound visualizing the left neck, looking for the thyroid, the carotid artery, and the internal jugular vein. Access is generally going to be between the thyroid lobe and the carotid artery. And so finding a good route trajectory where we want the tube to go, usually about a couple centimeters above the clavicle, and then planning out where this tube is going to lie across the chest so that it's good for patient comfort without any kinking. Once we identify those spots, the assistant who's managing the balloon in the esophagus inflates it. We're not looking for full inflation of the balloon, but just enough to really distend it well, and then provide some mild traction to visualize that balloon in the cervical esophagus. We do that under fluoroscopy, and then while watching with the ultrasound at the neck, you can see the balloon emerge into that space, bringing the esophagus up towards the anterior part of the neck, and usually splaying the carotid and the thyroid. That window is usually nice and short, really easy to see. If it's not formed, then a little bit of hydrodissection is performed there to separate those two structures. Generally here, we use a 21 gauge needle to then directly access that balloon under ultrasound, making sure to not hit any important structures.
Okay, so can I ask, one more thing so I can visualize it in my head? So is your ultrasound kind of like in a transverse plane right now, or is it more obliqued?
Yep, a little bit obliqued, just because I like to get the needle as deep into the balloon as possible. Because as you can imagine, you're essentially popping a balloon, and you have a little time window that you can get a wire through that needle into the balloon. And that's the most common difficulty. Exactly.
Gotcha. Okay.
So get that needle into the balloon using kind of a lateral-ish approach with a little bit of downward trajectory. Once that needle is in, the wire gets advanced quickly into that balloon under fluoroscopy, looping it into it. And then both the assistant and the physician push the wire and balloon together down into the distal esophagus or stomach.
Wire of choice?
I am a nitrix guy. I love nitrix wires. Nice and smooth, and they have a little bit of body to them. So.
And then what length nitrix do you use for this part?
I go with a 180, something of a reasonable length, so that way you don't lose it and you have a lot of extra backing to it. You're not going to be using any long microcatheters or tubes. The tube we generally place is a 45 centimeter, 14 French tube, just a generic pigtail multi-purpose drain.
Okay, cool. So you got your wire looped up, the nitrix looped up in the balloon. You're pushing the wire, your assistant's pushing the balloon. You guys go down and meet in the stomach. Okay. All right. Now what?
Now the hard part's done. You pull the wire, retract it slightly out of the balloon. The assistant pulls the balloon out of the stomach. We're safe there. And then exchange your wire for a full-bodied 035 wire, usually an Amplat, so 180.
You do that kind of just like a 4 French comfy all the way down?
Little 5 French, 65 Berenstein is usually what I use. But anything that you feel comfortable with that doesn't have a lot of angle to it should be just fine. And then once you have the body wire to work on, you just dilate it up and push a 14 French tube over top of that.
Okay. I think we might have skipped a couple steps. And excuse me, I've never done this before, so I'm trying to visualize the whole thing in my head. But you have your 5 French comfy down. What's your wire of choice to work over now?
Yeah, absolutely. I'm an Amplats fan. It's got a lot of stiffness to it, hard to lose. That's 180 is good for me.
And then you pre-dilate before you put that 14 in? And if so, how do you do that?
Yeah, usually I like to pre-dilate with a Kuhn's dilator because I like to remove the as many exchanges as possible. So a 14 French Kuhn's usually is enough. And then just use the plastic stiffener on that MPD to kind of get it down in place.
Nice. Okay, cool. And so I think you already said this, but what length MPD do you place?
45 centimeters generally. If you have something a little longer, that works as well. So this sometimes can be a little more comfortable for the patient if you have a 60 centimeter or something like that. But typically the 45s are good.
Awesome. Well, yeah, that's kind of start to finish. Lisa, you look like you have something to add here.
I just wanted to bring up kind of a fun little add-in with that. We do like to lubricate the balloon with lidocaine jelly. Previously, we just lubricated it with not lidocaine, and we found that the patients had less nasopharyngeal pain with using the lidocaine jelly over the balloon. So I think that's a critical part to also put into that procedure. And with securing it to the skin, and Ethibond is much better than using a Proline, much more comfortable for the patient.
That's a very interesting point you brought up about the balloon. And now I understand a little too why you wanted to use a short balloon to go in, because it does have to make that turn, right, from the nose all the way down. The Z-Med balloon you're talking about, is that kind of comparable to like an angioplasty balloon, or is it more like a low compliant balloon, kind of like we would use for EVARs or something?
Yeah, pretty typical to an angioplasty balloon. It's got a fairly firm body to it, so it can be a little tricky to puncture sometimes if it starts to roll. But usually you're very close to the surface, and with a little bit of stiffness and body to the balloon itself, I feel like it doesn't rupture as much, kind of pop in some dramatic way. So it gives you a little extra time to work.
Now, Lisa, when you guys were trying to convert this procedure from the Japanese kit to our kit, what were the biggest pieces of equipment that you kind of wish we had here?
Well, in Japan, the catheters are smaller and more malleable and smoother and have a lot less discomfort for the patient than what we have currently. So, and they also have PTEG. They have one that actually goes down to the jejunum. So if you really needed to do distal feeding, you could do it with that as well. So there's just it's a beautiful little kit. And unfortunately, when we looked at getting the kits here, because it's not like you're putting them in every day. And so it wasn't justifiable cost to get them. But we did look at trying to get them, and maybe we need to do something on our own here. That might be a nice entrepreneurial effort.
2 features when I've looked at these that I wish we had was they use specifically a rupture-free balloon. I'm not entirely sure how that works, but more consistently, they don't pop quite as fast. And I think there's some videos online where you can see the needle entering the balloon, and there's almost zero drama over the next 10 seconds, which sometimes can happen in the room. And then additionally, they can be pre-formed catheters that have a natural U shape, which would be really nice just to kind of keep a very low profile for the patients.
Oh, I see. Okay. So it has kind of like, what I'm thinking of is like PD catheters that have that swan neck, So
Exactly.
something like that. They have that there, but we don't have it here. I don't know. I feel like G-tubes are kind of like this orphan procedure, right? Like it's not sexy. It's not something that device companies are going to like put money into, but it's like something we deal with every day. I mean, yeah, I agree with you, Lisa. Just finding somebody who can kind of create that will be so clutch here. Okay, so now the tube is coming out, and this is really just percutaneous. It's not tunneled. It's really just kind of coming out because you don't expect it to be in for a really long time.
Mhm.
Okay.
We have tried a tunneled method, but we don't have any catheters that have a cuff to them. So we weren't sure what it was going to do. And the one patient that we did try, unfortunately, did get a tunnel infection and had a pretty severe amount of leakage. So we kind of abandoned that idea. But I think there are some other reports of PTEGs being performed as a tunneled procedure. It does make sense to me, but we just didn't have great outcomes with it. So.
Any kind of special dressing that you do on the site to help it in the immediate post-procedural phase?
No, you just warm soapy water, honestly, is the best care for it. And then just keeping it nice and clean. It shouldn't leak. I mean, that's the whole point. Like it should just be such an easy procedure for patients. And we just have them wash it with warm soapy water and keep it clean and dry. They can disconnect as they need to, put a scarf around their neck so that patients can go out into public and not feel like a patient for a day, take a shower, all the things. So they can't go swimming, but the rest of it that they can do. So it's a pretty simple post-procedure type of care.
As far as some leakage goes, I think we just put kind of traditional gauze on it for a few days, and after that it can be removed, but a little Tegaderm over top is helpful, particularly in the first week. If the patient does have some leakage, usually being more upright is very helpful, as you could imagine, if they're having some reflux or anything like that. So,
and placing it to suction. It's a lot. They have those nasopharyngeal secretions that sometimes can wick out along the catheter as well. So, but mostly it's just keeping it clean.
So yeah, let's talk about the suction postoperative. Kara asked me this question, and I was like, I'm not exactly sure what this means, but do you put all of these to suction, kind of continuous suction afterwards, or is it just for a short time after the procedure?
Yeah, in my experience, I would say it's kind of patient dependent. So either continuous or low intermittent. Some patients on continuous suction do notice some pain. I'm not sure where that's from. And so low intermittent suction seems to help those patients. If you have a pretty severe bowel obstruction or a lot of fluid building up into the belly, that's the time I think continuous suction is the best. We also have patients who, when they're going up and about and living their daily lives, they're not connected to suction at all. So we cap the tube and we give them essentially a large volume syringe that they can use to manage their own suction at home. But we also try and hook them up with home health care that gives them a suction machine so that it makes it easier for them.
And I was just going to say, it just also depends too, because we do have patients that like to have fluids or to take in a protein shake. And so we do have them clamp it for that time. And then 30 minutes after they're done consuming whatever it is that feels good to them, then they can put it to suction as well. So there are ways to make it a much more palliative way and really improve quality of life for these patients. You can also use it for medication delivery. You can crush up medications, or it would be more ideal to have them as liquids, but you can crush them and put them through the PTEG as well. And then we just suggest that you thoroughly flush it, because some of those medications can get stuck in the tube just like a traditional percutaneous tube. And then we, again, have them hold off on suction for at least 30 minutes before placing it if they are doing it for medication delivery as well.
It seems to me that you need patients that have a slightly higher level of agency than kind of maybe your average G-tube patient. Is that something you screen for before you're placing these?
Absolutely. In that pre-procedure care, when I said the most important thing is to talk to the patient first, partly it's to make sure that either they know how to manage the tube or they're able to, or their caretakers are thoroughly educated. Because if they change states or they go to another location or they go to another facility, they're sometimes needing to educate other people. And then they also need to be able to educate the nurses who are taking care of them at home or anyone else they may come in contact with. It's not particularly challenging because the tube itself just needs to be flushed and then understanding when to use it for venting. But it does take a little bit more agency, as you said.
And it's pretty standard. You're kind of doing the 14 French tube for everybody.
Yep. Certainly you can go larger. At a different facility I was at, we used 12 French tubes because that's the 45 centimeter tubes that we had. You could certainly go larger if you needed, but pretty standard. We seem that 14 French seems to be just fine.
Cool. Let's talk about exchanges. What's the exchange process for these, and how often do you recommend that they exchange?
Yeah, absolutely. This is one of the nice things about it is since we're just using regular multi-purpose drains, it's just like doing a drain exchange for an abscess. Cut the tube, advance a wire. Generally, we use NAMPLATs just to make sure that everything's stable and safe. But cut the tube, advance a wire, exchange it for a new one, and then loop it back in place and add a suture. Generally, we're doing this on average about 2 to 3 month interval. We're a little flexible on that depending on how well the patient is able to take care of the tube or if we've had any issues with clogging or misplacement or displacement. But generally, that's our interval.
Okay, cool. Yeah, and then do you use general anesthesia for that too, or is it just under conscious sedation?
These are very well tolerated, so just conscious sedation or local anesthesia.
Awesome. Yeah. Okay, so let's just talk about kind of troubleshooting during the procedure first. And I can already tell the part where everybody's like sphincter gets tightened is probably when you're poking the balloon. You've poked the balloon and now you got to get that wire in, right? But tell me other places that you've seen the procedure go haywire.
Yeah. So first part is always visualization. And part of this is a good pre-procedure workup. So when you're inflating the balloon and retracting it into the esophagus, sometimes you don't see it with the ultrasound. And then it's a bit of a troubleshooting tool. You want to use your tools on hand. So ultrasound, but make sure you ultrasound both sides. You're using fluoroscopy. We add a little bit of contrast to our balloon so that way we can see it and visualize it. Sometimes it takes a little bit of manual manipulation at the neck. So either the assistant or somebody else is able to push on the contralateral side or other locations to try and manipulate that esophagus into that left aspect between the thyroid and the carotid. Sometimes it also takes bigger or smaller balloons. We've even used a double balloon technique where we've taken 2 16 balloons and paired them next to each other to give it a wider approach as opposed to kind of a circumferential dilation. And that helped in one instance. So visualization is key. If you can't get it to migrate from the right side to the left side or visualize it enough, I think that's the time you want to cancel the procedure because there are some critical structures in the neck.
Yeah, not really one that'd be good for just a fluoro-guided stick for sure.
Yeah. And so that portion is probably the most important portion after getting that needle and wire into location. The other thing to pay attention to is accessing the balloon itself, making sure you can see your needle tip really well. Sometimes when you get the needle into the balloon, you can no longer see the tip because some air is introduced or something like that. And there have been reported instances of adjacent structure injury, particularly the trachea. So tracheoesophageal fistulas here would be a major concern. So just making sure you have very good visualization and everyone is on the same plan. So your assistant kind of needs to know exactly what's going to happen and maybe have a thorough talking to before the procedure to lay out a plan of what we're going to do.
Okay, cool. And then after that hard part, what else can go wrong or you've seen kind of go wrong before?
Fortunately, I haven't seen the wire loss after placement. Usually the wire is partly in the balloon and flips its way out. And then you're dissecting down the mediastinum. Obviously, you want to keep a good eye of fluoroscopy and watching your wire tip, making sure that it's making within the balloon and being pushed down. But other than that, some dilation, just making sure that you're dilating in line with the wire and using robust wires to do so. As you can imagine, kinking a wire and then dilating over top of that can be pretty dangerous also in this space. I have seen the wire lost one time in that way. So just making sure that you're using a liberal use of fluoroscopy or you're comfortable with the way you're dilating through the tract. Other than that, pretty straightforward. Positioning the tube itself, I think, is important. We try and place the pigtail of the catheter near the fundus of the stomach. If you advance it too far, sometimes it has the possibility of advancing later on, usually after the procedure, into the duodenum, and that doesn't provide usually the venting that you desire.
And also just making sure, too, that the patient's gastric contents have been adequately suctioned prior to the procedure, that stomach is empty, because we had a patient where that did not happen and there was aspiration. And especially when the balloon dilation, it can get a gag reflex. And so making sure that that's done first and foremost is also very important.
And that's why we've kind of shied away from moderate sedation as a procedure. I have done a couple in that regard and they've gone okay, but making sure that the patient is adequately sedated, because as you can imagine, having a balloon in your esophagus while being poked is not a comfortable experience. And also, as Lisa said, can lead to aspiration and gagging and vomiting.
Definitely. You guys do any tracheal dilations at the IRs do that, or is it pretty much just GI? Okay. Back where I trained, we did them all under fluoro, and I think I kind of remember that was one of the biggest issues, right? Is like you have this person with a balloon in their esophagus, and we did them under sedation, but they'd just be gagging, and totally get it.
To Lisa's point earlier, adding lidocaine certainly helped in that regard, both post-procedure and during the procedure. So if you are going to be doing this with moderate sedation, I highly recommend using lidocaine jelly.
Tell me a little bit about post-procedural care and management, and then like also specifically what antibiotics do you put them on afterwards?
Yeah, absolutely, Lisa. You can probably speak to post-procedure care.
Yeah, so typically what we do is antibiotics, we don't typically keep them on. That's not something that we typically do. However, making sure that they have home sections set up is important, whether it's through hospice or whether it's through their home care, whatever it is, and making sure they have that is very important. The other thing that we look at is making sure that they flush the tube 3 times a day with 30 cc's of water, just to keep the patency of the tube open. And then we also suggest that they, after medication delivery, to again flush it with 30 cc's of fluid prior to and after to keep that patency of the tube. We do not use it for feeding. We highly recommend that they don't put anything down. I mean, if they could, they'd want to put a cheeseburger down this tube. And so we have to, again, patient education and caregiver information is really important that this is to be used for venting only. And then we also remind them if they're having sips and chips or taking in fluids or protein shakes or milkshakes to clamp it and then reinitiate suction, and to make sure that they are flushing after the suction if they have something sticky or something that could potentially clog the tube. Care of the wound is just warm soapy water, and they usually do really well with it.
As far as symptom management, we do educate them a little bit. If they are having symptoms, that's the time to attach to suction or use the syringe. If they're not having symptoms, then sometimes they can get by with just capping the tube and trying to ignore the tube's existence. Antibiotics, like Lisa said, generally we don't do anything post-procedure, but pre-procedure we do recommend Ancef just for the usual skin flora.
All right, cool. You mentioned that it needs to be in place for a certain amount of time to let the tract form before we could take it out. What's your standard time for that?
We generally recommend 2 weeks just to make sure that there's a little extra stability there. I don't think there's any specific data about that, but we've used that number and it seems to work pretty well.
Cool, man. Anything else that, our listeners should know about if they maybe were to want to start placing these at their institutions?
Yeah, absolutely. I think there's also some reports of laryngeal nerve injury or potential laryngeal nerve injury. We're in that zone. We have not come across that. I think if you're doing a more deep, kind of more inferior placement or more lateral approaches, maybe that would be a major concern, but definitely something to pay attention to and educate the patient about. Also, bleeding in this area is pretty unlikely, but you can injure the thyroidal artery, which is going to be nearby. So making sure that you're doing a good Doppler evaluation beforehand so that you know your intervening structures. Leakage around the tube is somewhat common for the first couple of days, but it usually goes away after tract formation. And so after about 10 days or so, patients don't really complain of that. Malpositioning down the road is the most common thing. So retraction of the tube into the esophagus or advancement of the tube into the duodenum. And patients usually know pretty easily. They'll come in and say, hey, the tube's not doing anything. I'm not getting any fluid out of it, or I feel very full. And so just bring them in. Usually it's very easy to re-advance. We have easily been able to recannulate the tract if the tube falls out, as long as the tract has been pretty well matured. Usually 4 or 6 weeks or so is when we see these patients. And so you can make it back through, but if you need to, unfortunately, that does require a new stick. So we do reset them up for a general anesthesia, usually as an outpatient.
I would just like to add something too, and that is to educate your staff, educate your nurses that these patients are coming back to, of what it is and what's intended to be used. And that was a big thing that was really important. I mean, I actually had nurses that thought it was a central line. And so it's like making sure that they know what this is and what its use is and what the care is, The other is your outpatient staff so that you can help troubleshoot your patients, educating them as to what to look for when it's time to bring them in. There's a lot of education when you bring in a brand new procedure, but it's just so critical because a lot of these things, when you bring on a new procedure, you forget about that they go back to these inpatient floors. And you will save yourself 5 million phone calls if you take the time to make sure that everybody knows what it is and what it's cared for and how to use it appropriately.
Yeah, I think over our nearly 10-year experience now, the most important thing to building this practice is making sure that on a kind of semi-annual or annual basis, re-educating the physicians, the referrers about what this tube is, how it's available, and making sure that both you yourself and your colleagues are aware of what this tube is and the management of it.
Man, isn't that what the kicker is for IR? Like, we can do these cool procedures and in 15 minutes, but we got to spend months and months explaining what we do before we can actually do it. Oh, man. Well, cool, guys. I'll just kind of break the third wall here, but is it the third wall or the fourth wall? I don't even know. But is there anything else you guys want to talk about kind of before we wrap it up?
I think that pretty much hits it. I think the most important thing is just making sure that you're educating everybody around you, because we've had a couple of fellows go out into the world and then the patients don't know what to do after they get their tube. There's some pretty good papers out there now, I think, that kind of show the anatomy and the review. So they're pretty easy to find. So I don't think we necessarily need to point to any, which is good.
It's just such a great procedure for the right patient population. I just would hope that every interventionalist, if they think about this as an option for your patients, because for the right patient, it changes their lives. It changes their last few days and gives them great quality of life for time with family. And I just want to reiterate that this is what this was brought here for, is to help those patients through a very difficult time and to always keep that in the back of your mind for a possibility.
Can you tell me a little bit more about the patient experience of having this tube after it's placed?
The most restrictive things that we see from the internal medicine physicians or whoever is, patients aren't going to want a tube at the neck, it's going to hurt, all this kind of stuff. And I would say, at least in my experience, patients have been very happy. They're not, their alternative is a nasogastric tube. And even if that nasogastric tube comes out and they have this tube, they're not sad about it. It doesn't really affect their daily life. And
it's out of sight, out of mind. Yeah.
Exactly. And you can usually cover it pretty well. So Lisa can probably really speak to that because she's personally had a lot of interactions post-care.
It's wonderful because these patients are so grateful. It just gives them, peace of mind. They can interact with their children without having something in their face. Or having a leaking percutaneous tube, or it's something they can go into the shower. They can go out in public and just kind of wrap a scarf around it, and they're so happy to be out and engaged back into the community for periods of time. I have not had one patient yet that wished they wouldn't have done it, if I can tell you that. They actually become much more happier and are very grateful. And it gets them out of the hospital and back home, all the things to get back to a more quality of life. But like I said, we had one patient that had it for 65 days. And it was her lifeline. And every time I would see her for an exchange, she would thank us over and over again for this because it was such a better option for her. And it's easy to care for with the right education. Again, making sure they know upfront what to expect and then reassuring them on the back end when the procedure is done. And again, educating staff so that they can help troubleshoot or address any type of questions they may have once they leave the hospital.
Awesome. Well, Alex and Lisa, thanks so much for coming on the show. I feel like I know way more about this topic than I did before we started. And yeah, I really want to thank you both. If there are folks who are interested in kind of performing it at their facilities, may they reach out to you kind of for some guidance?
Absolutely. It's been a pleasure talking to you about this. And I think it's one of our passion projects here. So please reach out to us anytime.
Yes, thank you so much for having us. And thank you for allowing us to talk about PTEG. We believe in it. So thank you for having us.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Baheti,
Michael Barraza, Sabine Dond, and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.